Hello everyone, this is Shadi Reyes. This is ARCH 2022. With me is Dr. Karim Al-Azizi. He is interventional cardiologist at Scott & White. So Karim, you give phenomenal talk about physiology, and as we talked offline, you are the top recruiter for Define GPS. So before we go to the trial, tell us about the importance of post-PCI normal IFR.
Thank you, Shadi. Thank you for having me. Always excited to be here and see everyone in person. So the role of physiology post-PCI was really a question when Define PCI as a study came out, about a year ago at TCT, and it was a trial that was an eye-opener. It looked at what kind of ischemic burden did we leave behind post-PCI in the best hands, in the best labs, and really experienced interventional cardiologists. So what we found is that in a blinded study where operators were blinded to the physiology post-PCI, whether they used imaging or not, 25% of patients left the cath lab with an abnormal IFR. Wow. That's 1 in 4. And so if we're expecting to actually do and have better patient outcomes, and perhaps comparable to CABG, although 2 different modalities or 2 different ways to revascularize, I do believe that we need to work on that. Now, when the core lab looked at that, 80% of those cases were actually either a third within the stent, a third just proximal to the stent, or a third just distal to the stent. There was obviously the small group of patients that were primarily diffuse disease. So the question becomes, is there a way to perhaps utilize a technology to optimize and try to get to a non-ischemic value? So as a follow-up to that, the Define GPS study came out in order to basically randomize patients between either gold standard PCI, you did your IFR, you want to do an IVIS guided or an OCT guided PCI, or you utilize the Sync Vision system to co-register your physiology and really map out your intervention. Whether you tag on imaging to it, which is obviously recommended, or not, that's a different story, but then performing post-PCI IFR and trying to achieve beyond the benchmark of 0.95 that we saw presented at TCT, which based on the curve, the area under the curve, and what we saw on that presentation, the 0.95 number seems to be where the cutoff would be for perhaps successfly alleviating all of the ischemia in the vessel post-PCI. So that's an important study we're happy to be part of, and the enrollment is going, multinational and multi-center, and we'll see if this technology really pushes us beyond where we can actually revascularize patients successfully and actually have them leave the lab with a non-ischemic IFR.
So the challenge we're having now is to ask people to do physiology pre.
Right.
Now we're going to tell them do physiology post. Do you think this is going to be in a practice hard to deliver that message to the interventionalist?
Good question. Once we start seeing quality, once we start seeing hard outcomes linked to that, and once it starts to move guidelines somewhat, we will see that. I mean, same thing applies to imaging, right? So really adopting these 2 technologies in the day-to-day practice, thankfully now FFR, IFR have been upgraded to Class 1A indication in the most recent guidelines, which I think is important to understand and feel more comfortable in treating those patients accordingly when it comes to an intermediate lesion. Post-PCI IFR seems to be still in its early phases and needs a little more of data, which we are gathering through that trial. And once we have that, I think it will shed light on a lot of things, because eventually this may reflect to then angio-based physiology, right? And then you take out that complexity. So you may be able to do a post-PCI, for example, physiology just based on angio on a technology that was validated against your wire-based physiology. So there is a lot of room. I think the proof of concept is there in that trial. How we will change things in the coming years is going to be a question.
The second question I have is about, do we have some argue about you do your work on the pressure wire? And is it still a reliable wire to remeasure, or I have to put a new wire? Is it something looked into, or we should keep in mind?
It's a great question. So what we've used in Define PCI was mainly the Verata wire. And that had a lot of issues. Obviously, the defined PCI and defined GPS studies are sponsored by Philips. And so the OmniWire, on the other hand, what we found in our day-to-day practice, as well as in the study, is that it is more reliable. You're less likely to drift. As long as the lesion, the longer the case, the more the complex the lesion, the more likely you're going to notice drifts, and perhaps the wire maybe malfunction. Right. But I think the new reiteration of that wire definitely made a difference in terms of actually utilizing it during your intervention and then reconnecting. In our experience so far, we haven't seen major drifts, but the longer it stays in the body, the more we find that there is more than likely a drift that will happen, and you will have to adjust for that and normalize.
Absolutely. Well, Aziz, thank you so much for your time.
Absolutely.
Really a great insight about physiology. Please watch this video and others on the YouTube channel. This is Shadi Reyes from ARCH 2022.